I would like to thank OIF and Tracy Hart for initiating this series on OI, and Michael Stewart for actually organizing everything. So I'm happy to introduce the first speaker of this series. It's Eric Rush, and Eric has been a prominent member of the OI scene for many years, first in Omaha and the last several years in Kansas City. And there he is a geneticist and professor of pediatrics. And today he's going to talk to us about diagnosis and genetic testing in OI. So Eric.
Unmute myself. There we go. Thank you very much, Dr. Rausch. Thank you to the OIF, and thank you to everyone who made this possible. I really appreciate the opportunity to get to kick this off. It's an exciting thing to have, and so today we're going to talk about the diagnosis and genetic testing for OI. And please let me know. I think everything should be looking okay with my slides, but Michael's is always my technical consultant because I run into technical problems not infrequently. So we're going to talk about diagnosis and testing. So here are my disclosures for research support consultancy and any stocks. So what are we going to do today? So we're going to have some fun, and we're going to talk about the clinical diagnosis of Osteogenesis Imperfecta, and we're going to talk a little bit about the use of molecular testing in an OI, which has become a very important aspect of the diagnostic evaluation. And then this is going to be followed up by the opportunity to ask some questions of the group, and we'll also have the opportunity to go over some cases. I know Dr. Rausch has one of his fellows that's going to be presenting some cases, and I think those will be really great. So I want to start off just putting OI a little bit on the map when we talk about skeletal dysplasias, because I think sometimes we don't always have the sense. And before I really started doing this, I really didn't have a great sense for what the epidemiology of skeletal dysplasias were in relationship to one another. And I think about this in terms of a composite. You know, what is the overall incidence of skeletal disease? And we think it's probably about 1 in 4,000 to 1 in 5,000, of which OI is really the most common. And so the statistics vary, but the statistic that I prefer suggests that OI is probably about 1 in 12,000. And so it's relatively common compared to a lot of the other skeletal disorders that we think of as being also relatively common. And so what really is OI? And I think we all, at least most of us who are on this on this echo, have a sense for what we consider OI to be. But we consider it to be really one of the prototypical bone fragility disorders, and we associate that with decreased bone mineral density, and that's variably true, as we'll find out. And there's also a tendency to fracture with minimal trauma or no trauma. And there's a tendency for variability of short stature, but there can be normal stature in some patients with OI, which can sometimes be a bit of a diagnostic confusion. But oftentimes these patients will have a height that's less than expected for their mean parental height. Blue sclerae are frequent. I find that these are overinterpreted, and we'll drill into that a little bit later in this presentation. And then hearing loss can be present. And one thing that's sometimes underappreciated, but has been known about for actually several hundred years, is the joint hypermobility aspects of OI. So what about family history and diagnosis of OI? You'll never get a geneticist to say things like 0% or 100% very well. You don't get it very often. This is one of those times when you'll hear me say that taking a family history is necessary in 100% of cases, even if you don't ultimately decide that there is a family history, because both inherited forms are possible, and de novo, or new changes that result in OI, are common. And some interesting new research has suggested that in patients with type 1 OI, the majority actually probably have inherited disease. For patients with type 4 OI, it's probably about half and half, and for people with type 3 OI, it's mostly new changes with a smaller number being inherited. And of course, type 2, this is going to be all of the de novo or new changes. Now, this is looking at this from the phenotype perspective, and just in terms of what people look like. If there's a history that's compatible with that condition. But what's interesting is there's also known to be asymptomatic or minimally symptomatic parents who exhibit either somatic or gonadal mosaicism. And gonadal can it seems to be relatively common, and there's estimates that are as high as around 16%. And so this is a non-trivial incidence of asymptomatic or minimally symptomatic people who do have that level of mosaicism. And in many of those cases, of course, they're really going to be this is going to be an unknown phenomenon. They're not going to understand that they have this potential until they have children of their own. So what about radiographic findings? Well, like other aspects of this condition, they're really variable. So we have patients with type 1 OI who, if they don't have an active fracture, may have relatively normal imaging. And but commonly described findings for patients with more involved disease may be the fractures in various ages and stages. Again, this can vary based on where you're getting a patient in terms of the severity of disease and also in their age. Sometimes you'll see sequelae from previous compression fractures. Sometimes this is referred to as codfish vertebra, but I don't know that that's to my eyes that's not the perfect descriptor. Patients may have Wormian bones. They may have small bones kind of interdigitized within the plates of the skull, and they may have apparent low bone density for age. And this is if it's on plain radiograph, because you're not really going to accurately assess bone density on plain radiograph. Or if the patient has DEXA or PQCT, some sort of densitometry, you may actually document that low bone mineral density for age, which can be helpful in substantiating the diagnosis. Again, not perfect, but it can really be helpful. And so fractures in patients with OI, again, the fractures can vary, but you see this fracture on the left radiograph, and this you might consider this a more prototypical fracture. This patient is fracturing kind of not quite mid shaft, but pretty close to mid shaft, and then you can tell that there was a more proximal fracture previously that's still in the process of healing, and so again, different ages and stages, but that's a relatively clean break. And some of the patients with more involved disease, you may see these sequelae of multiple fractures, almost a crumpled appearance to the bones, and you may also see the ribs that have multiple fractures, and you can see some beating of these ribs from callus formation. Now, again, there's a lot of differences in fractures that can result, but these are kind of some broad brushstrokes that I think about when I think about fractures in OI. So now that we kind of have set the stage a little bit for OI, kind of as a prototypical brittle bone disease, I want to talk a little bit more about the individual types of OI, and then drill into some of the aspects of OI that are really important, but in some cases may actually be overinterpreted. So we'll start off with a discussion of type 1 OI. So type 1 OI, or what we'll sometimes refer to as classic non-deforming OI. These are patients who typically present with an absence of inherent bone deformities. And what do we mean by inherent bone deformities? It means they're not born with them. They could still develop bone deformities later on due to fracture, but they're typically not born with those deformities. Their level of or number of fractures can be extremely variable. I've seen patients who I know absolutely have type 1 OI who have really had very few fractures. And I've seen people with very clear type 1 OI who've had dozens of fractures and really everything in between. Vertebral compression fractures are also variable in this case. If I was reading an older text not long ago, which suggested that patients with type 1 OI really didn't get vertebral compression fractures, and that certainly has not been my experience. My experience has been that like the other fractures, vertebral fractures can be really variable. People with type 1 OI have a tendency to have either normal growth or at least near normal growth. Frequently, they will find themselves on the kind of the lower end of the growth curves, or at least compared to mean parental height. And I find mean parental height is often a very helpful metric if you have a patient who is only slightly short statured. These patients typically will ambulate. Some of them will require some assistance with longer ambulation, but typically they're able to ambulate. People with type 1 OI, especially if this is not a familial form, if this is a de novo form, there may be a delay in presentation, and this delay in presentation may cause problems in both the kind of the medical knowledge and the diagnosis of that patient, but also may present with medical legal issues, because there may be some concern over non-accidental trauma in these patients. And so sometimes this can be an additional source of stressor for patients and families, above and beyond just the fact that they now have a child who has a new diagnosis. And I typically consider these to be caused by what we'll call haploinsufficiency variants in COL1A1. So what does haploinsufficiency variant mean? It means that you have some sort of complete loss of function of one of the two copies of that gene. There are many mechanisms by which this can happen, but those are kind of beyond the scope of what we're looking to do in this discussion today. Type 4 OI, or what we'll call common variable OI, and what do we call patients with type 4? You know, a lot of times phenotypically these are patients who don't necessarily match a type 1 phenotype, and they don't quite match a type 3 phenotype. Often will get lumped into there, and so there's a fairly wide swath of severity in patients that we consider to have type 4 OI. Again, I've used the term variable many times, but it's true that you really do get a lot of variability in both the bowing of the long bones, and also that can occur with recurrent fractures. And sometimes stabilization with things like intermedullary rods can be extremely helpful for these patients that have both a history of a lot of fractures and also a lot of inherent bowing of those bones. Vertebral compression fractures may be more frequent than a patient with type 1. We have patients with type 4 OI who have maybe moderate short stature. I've seen patients who I would consider to have type 4 OI that have conspicuously normal stature. And there's a subset of patients with what I would consider to be mild type 4 as opposed to type 1 OI that are actually kind of challenging to detect. And this is based on the fact that these are really conservative changes in the gene COL1A1 or COL1A2 in most cases. Type 3 is a little bit different. This is what we'll call severe progressively deforming OI, which these are patients who will frequently have both inherent deformities of the long bones and spine, and they'll also have can have multiple compression fractures, typically variable short stature. This can be anywhere between moderate and severe. We do see some people with type 3 OI ambulate, or at least ambulate at some points in their lives, but many people with the type 3 OI will require a wheelchair or some other assisted device for mobility. And the variants that we find in type 3 OI can often be very similar to what we'll see in type 4 OI. You know, it's not necessarily a difference in the type of variant. It can be a little bit of difference in, say, how conservative the substitution is, whether it's COL1A1 or 1A2. There can be some differences there, where it's located within the gene itself, because there's some variability in that as well. But in most cases, these are caused by missense variants in COL1A1 and 1A2. Okay. And contrast this further with patients with type 2 OI, what we'll call perinatal lethal OI. These are patients that of course they have very severe bone manifestations, including multiple fractures. They typically will have very small thorax size, and ultimately the respiratory failure and thoracodystrophy are typically the cause of death in these patients. Vertebra can be very hypoplastic, typically multiple compression deformities. And again, in most cases, these are caused by missense variants in COL1A1 and COL1A2. There are a subset of patients that will present with a type 2 or type 3 phenotype who will have a genetic change that is in a non-procollagen 1 gene. And we'll talk a little bit about some of the mechanisms of disease, and we'll talk a little bit of the landscape of OI molecular genetics in just a little bit. But these patients are on the severe end of that spectrum, and it really is a spectrum. And one of the things that I always tell colleagues and tell families as appropriate is that in many cases we're really diagnosing type 2 OI in a post hoc way. You know, you have a patient who clearly has very severe OI. You know, some of those patients who have very severe OI who will ultimately go on to survive. And you know, I would argue those patients do not have type 2 OI. Those patients have severe type 3 OI. Whereas the patient who ultimately passes from their disease is the one that has type 2 OI, you know, in that first perinatal period, that first period of time. So, and again, these are just my thoughts on how do we categorize these things, but that's type 1 through 4 OI. And one that was a little more recently described phenotypically, and a little more recently described from a molecular standpoint, and a lot of work was done by Doctors Gloria and Rausch on this, is the type 5 OI. I typically consider this to be a moderately deforming OI phenotype. These patients may on surface look a little like a patient with type 4 disease. Sometimes their growth parameters are a little bit different than patients with type 4 disease. There are some phenotypic differences that can really be helpful for you diagnostically with this condition that are not generally present in other forms of OI, in that they tend to have things like exuberant callus formation, and this occurs oftentimes over long bone fracture. And you can see in the bottom radiographs, kind of on the left, that's a pretty big callus there. You can see that's post-traumatic, and they do tend to resolve over time, but that's a pretty big callus, and that should give you some helpful clues. And they also have a tendency over time to get calcification of the interosseous membranes between the radius and ulna, and that calcification of the interosseous membranes can result in limited mobility of the forearms. And again, that can be both a diagnostic clue when you do a physical exam on the patient, which is hard to do for telemedicine, I grant you, but can be really helpful for you, and is also in many cases pretty obvious on radiograph. And these patients generally do not have blue sclera. They generally don't have DI, and these are both pretty rare. And these are changes to a gene called IFID-M5 or BRIL. So that's type 5 OI. So let's talk just a little bit about Dentinogenesis Imperfecta. This is a relatively common dental finding in people with OI, noting that it's more common in those patients who have pro-collagen variants compared to some other variants in different genes that still recognizably cause OI, but are not things that we would typically associate with DI. Knowing that type 1 collagen is expressed in tissues like dentin, and this results in discoloration of the teeth that are kind of a brown or gray color. The roots are short of the teeth, pulp chambers are large, and so they tend to be prone to both wear, and they tend to also be prone to breakage. And these can also, when you have teeth that are worn and break, they can get kind of secondary caries within those teeth. And we find that the incidence of DI actually does increase with overall disease severity. And so it's not rare to find DI in patients with type 1 OI, but it seems to be a minority of those patients, whereas the majority of patients with type 4 and type 3 OI will have OI, or will have DI rather. And again, I noted that OI caused by other genes, they tend not to feature DI. There have been uncommon case reports of people doing so. But really, at the end of the day, we're looking for treatment that will include maintenance of overall dental health, scrupulous dental hygiene, and restoration if necessary. So those are our patients with Dentinogenesis Imperfecta. What about blue sclera? So blue sclera or gray sclera are common in OI, and I'm not sure if these pictures are really you can see these real well, see these little eyeballs in the pictures here, but these are really common. So type 1 OI, we really do typically see blue sclera, not 100% of people. Type 3 OI, they can be blue or gray. Again, none of these are 100%. Type 4 OI, we do see maybe a higher percentage of those people with normal sclera that we will put in that type 4 category. But I don't really agree with some of the idea that type 4 OI should really be considered common variable OI with normal sclera, because I've definitely seen a lot of people that I would consider as having type 4 OI who've had some blue or gray sclera. And one of the things that I would point out to the group is that light blue sclera are really common in otherwise normal infants, especially infants that are kind of fair skinned and fair haired. And sometimes we'll have either requests from colleagues to discuss a patient that has blue sclera that has a colleague concerned, or we'll have patients that are evaluated for findings that are concerning for non-accidental trauma, and the existence of light blue sclera are viewed as evidence that is strongly supportive for Osteogenesis Imperfecta. And so these two infants here do not have OI. These are my two daughters. who, as both as babies, they're not babies anymore, but as babies, they both had nice light blue sclera, perfect light blue sclera, and they're fair-skinned babies. And one of my daughters has red hair, the other has really light blonde hair, and so this is really pretty expected that they would have light blue sclera. And then by the time they got to about 18 months of age, it pretty much went away, and they don't have blue sclera anymore. And I just thought these were also two pretty cute pictures too. So got to throw those in. So what about the genetics of OI today? And so these are, so I've referred to these by their type in terms of molecular designation, and that's controversial. And I'm not sure that necessarily defining these as OIs type 1 through 20 is necessarily helpful from a kind of a phenotype and management standpoint. But I put this up to really just give you an idea of how much the landscape has changed over the last 15 years in terms of our understanding of the genetics of OI. Because if we'd been having this conversation in 2005, we would say, yeah, there's these two genes, these two procollagen genes, and then there's a handful of these patients that we really can't characterize as present. Some of them have a phenotype that's a little bit different. Some of them seem to be reading from the typical OI playbook. But so we've really done a lot of work over the last 15 years to answer some of those questions, and so that's extremely exciting. And there's also been a lot of knowledge about what the functional implications of these variants are. And so in addition to just knowing how to diagnose these patients with different kinds of OI, we've also learned a lot about how collagen is processed, how the osteoblast is formed, how osteoid is mineralized. And so we've really learned a ton about the normal function of bone by what happens when these functions are not working properly. And so these can include procollagen production, include lysyloprolyl hydroxylation, chaperone or ER transport, mineralization, processing and regulation, and cell precursor fate, amongst others. So these functional implications can be extremely helpful for us to understand. So how does this really translate for us from a boots on the ground standpoint? Because I think all of this is very interesting to me at least. But at the end of the day, one of the things we're trying to do with ECHO is we're trying to help our colleagues that are out in the community be able to really to be able to manage patients, to be able to diagnose patients, to really be able to embrace the rare diseases, and for the sake of this ECHO, Osteogenesis Imperfecta. A lot of us, we have a little more luxury of working in tertiary medical centers, but we know that many of our colleagues don't, and so our job is to try to make this easier and to make this more understandable. And one of the ways that we can do that is with genetic testing. I still consider very much OI to be a clinical diagnosis. Having said that, genetic testing can be extremely helpful in understanding more about that condition once we're able to make that diagnosis. And genetic testing has become increasingly useful just in skeletal disorders overall. Because of the 461 described skeletal dysplasias, 425 of them have a known molecular etiology. That wasn't the case a few years ago. And one of those groups is, of course, group 25, osteogenesis imperfecta and decreased bone density, which is where we're focusing today. When we do approach a patient for genetic testing, I find that two key testing paradigms are often used, and this is used by me, by other people that diagnose patients with OI, and we're really looking at this from the standpoint of targeted testing versus expanded testing. And so some of this depends on how confident you are in the diagnosis and what additional information are you really seeking to gain. So for instance, targeted testing, you may just do procollagen genes alone, and that can be sometimes enough. In a lot of cases, that may be enough if you have a patient who you're very confident about. And in this case, you have a minimal burden of variants of uncertain significance, and we'll discuss a little bit about what those are. But you'll get limited information, and so if you don't get the diagnosis right away, you'll have to do maybe a second round of testing. With expanded testing, maybe you'll do a comprehensive low bone mass panel. You'll have a little bit more of a burden of those variants, but you'll get more information out of it. And so there's not necessarily a right or wrong answer in a lot of cases, just what tool are you using at the right time, and are you prepared for the downstream effects of the tool that you're using? And genetic testing also doesn't take as long as it used to. You know, even when I was a fellow, not all that long ago, genetic testing took a lot longer than it does today. And so for single genes or small panels, you may get your results back in 2 or 3 weeks. And a lot of times we find here that we may be dealing more with insurers for a greater amount of time than the testing itself actually takes. Larger panels, it can take longer, and and again, it depends on the lab, and it depends on how extensive your panel is. And then whole exome sequencing, that we don't see the need for that a lot of the time for patients who clearly have OI, but I won't pretend that there's never a role for it in rare bone disease. But you know, it's more like 6 or 10 weeks for something like that. And when I talk about smaller panels versus larger panels, there's really not one delineation. It's just sort of the eye of the beholder. And so there's just kind of examples that I would give as far as what would be a smaller panel and what would be a larger panel. When we order that testing and we get those results back, we're looking at this in terms of classification. We're really classifying this in 5 different categories, and these are pathogenic, likely pathogenic, variant of uncertain significance, likely benign, and benign. As the end user, you will generally not see the likely benign and benign variants because there's just too many of them, and they're confusing and sometimes distressing. But really what benign and likely benign variants represent is normal human variation, to the best of our knowledge. So what we're looking at is going to be the pathogenic and likely pathogenic variants. These are what we would consider to be clinically actionable. And as a practical matter, we do generally treat likely pathogenic variants as similarly pathogenic. We consider those diagnostic. There are rare cases in which a likely pathogenic variant, we may not think it fits very well, and we need to do a little more background, but really that's how we would approach those. Variants of uncertain significance are sometimes a challenge for us. Because there's a lot of things we'll have to do in the background to try to understand more about them. And so in the case of a clearly abnormal report, and this is not a patient with OI, this is a patient with a different condition, hypophosphatasia. But unfortunately, I couldn't find a good copy that I had permission to use of a patient with OI. But this patient is diagnosed based on the clinical findings. The variant itself is identified. Both the nucleotide sequence and the peptide sequence are identified. The gene is identified. The state is identified, meaning heterozygous, homozygous, compound heterozygous, and the interpretation, in this case, pathogenic, is defined. Those are all important things to include in a report to make them as clear as possible. Sometimes variants of uncertain significance also pop into this. Again, the more genes you find, the more likely it is that you're going to find a variant of uncertain significance. And these variants of uncertain significance are, again, in most cases, are a result of normal human variation. But in some cases, we do see interesting variants of uncertain significance that we need to follow up on. And a lot of this has to do with what is the nature of the variant itself. Is it concerning or versus more concerning? How close is it to being able to move in one direction, either towards likely benign or likely pathogenic? How well does it fit the patient? If you have a variant of uncertain significance and it looks nothing like the patient in front of you, you're often going to be a bit dissuaded from thinking that is likely your answer. But the more genes you do, the more likely it is that you're going to find a variant of uncertain significance. And so if we do whole exome sequencing for patients in which we're looking at everything, we tell patients really to expect those, expect at least one. Once in a while we don't get any at all, but we tell them to expect it so we can set those expectations for our patients, and so they're not so they're less distressed when one of those happens, and we can often still walk them through that. So what is the deal with variants of uncertain significance? Why do we have this method for interpreting those results like we do? Well, I find that a lot of times my non-genetics colleagues who find a variant of uncertain significance will make a set of assumptions about those variants. One, they will assume that they're probably benign. 2, they'll assume that they're probably pathogenic, or 3, and most commonly, they'll panic and they'll call me. And I would actually much rather have them panic and call me so we can walk them through that, and so they can understand why. And the reason why is because our guidelines in the US for interpreting these variants are extremely conservative. We want to make sure that if we're calling something likely pathogenic or pathogenic, we are 90% and 99% or greater likely to be correct about that. So, and the same thing happens on the other side with benign. And so there's a large swath between about 89% chance that it's benign and 89% chance that it's pathogenic, that we would call variant of uncertain significance because of how conservative those guidelines are. So that's why we get a lot of them, and that's probably on balance, even though it's frustrating and it can be time consuming for me. It's probably on balance a good thing to do, because we found over time that giving person the wrong information is demonstrably worse than having them have to live for a period of time with some variability and with maybe not a completely clear picture. So those are the kind of the broad brushstrokes and how we go about both the clinical and molecular diagnosis for patients with OI. So I know I've covered a lot of territory in a short amount of time. That's part of the kind of part of both the beauty and sometimes part of the challenge of the ECHO program is we try to do this, and so the didactic is only a relatively short period of time, and we have plenty of time for both question and answer and plenty of time for case review with further discussion. So with that, I will go ahead and end my discussion of this, and I would be more than happy to answer any questions that anybody has, and then we can move on to our cases.
So thank you very much. That was a great presentation, very informative. So if you have questions, you can put them in the chat function. So maybe I can start while people are typing away. I think what was interesting, you mentioned the distinction between